Any other questions before we move on? Because the next session is going to be interactive and somebody's going to have to open their mouth. No, huh? Okay, so let's try out some questions. And of course, as regards to questions, we have, I have some. Do you have time?
No,
Can, eh?
the mic. For them to answer.
Ah, okay, okay. Or maybe give them the code. Okay. Okay. That was from my old time. Luckily, I'm not the person who deletes his WhatsApps. So that was from, yeah, obviously that's from 2014. So 2014. My OSCE for the MCAI. So we're gonna start off. So how many of you have ever encountered a patient with a pacemaker? Wait, 0. Oh, pacemaker, ada. So what mode was it? What mode was your patient? I'm not talking about this patient. That patient may not be so visible, but never mind. For your patient, what mode was it? Quite some time ago. So, what are you going to look for in an ECG that tells you that this patient is probably paced? Let's say you have a patient that's ventricular pace. Pacemaker spike, okay? So, how are you going to tell that it's an atrial versus a ventricle pacemaker rhythm? Okay. So you look for the when was the spike? Was it before the P wave or is it before the QRS wave? So if you think that that is a ventricular pace rhythm, what do you expect the QRS duration to be? Prolonged. Why? Already blocked, huh? Okay, maybe that's one reason. But what's another reason why? Why is it prolonged? Where is the potential coming from? As compared, okay lah, since korang dah already bought your head kan in the morning kan, cardiac physiology kan. So, conduction, where does it travel from? Okay, SA node and then AV node and then bundle of his kan, and then Purkinje fibers. So why do they need these fibers? So that the conduction is fast. Yeah, so that when the conduction is fast, then everything is coordinated. But when you have a patient on a ventricular pacemaker, is the lead at the Purkinje fibers? Is the lead at the bundle of his? No, right? It's in the endocardium. So now the rhythm, instead of traveling from the AV node down distally, now he has to travel from the endocardium and then towards the rest of the ventricle. So therefore, the conduction is slow. So that's why your QRS will be prolonged. Yeah. But of course, your P wave will still be short because your atrium is small. So, what do you understand about pacemaker dependence? Have you heard of the term? Inspired to study. So what do you understand about pacemaker dependence? Okay. Yeah, so you can goreng lah whether the patient is fully dependent on the pacemaker. So of course the definition actually varies. So people do not agree on what is the ratio that you can think of in terms of pacemaker dependence. But usually when you look at the interrogation report, the company will provide you with the percentage of the pacemaker dependence. So usually anything more than 50% is generally dependent because you know that every other beat the patient depends on the pacemaker. Yeah. So let's go back to the basics of pacemakers. How do you describe the mode of a pacemaker? How many letters? 4 letters. 5 letters. Okay. What are they? I have my answer in my notes, so salam bocor for me. But for you guys, what are the letters corresponding to? The first letter is the paste. So which is the paste chamber? And so is it A? Is it V? Is it dual? D? And then after that, which one is the sense chamber? So the same thing. And then the response. So forget the other 2 letters first. Let's go to the basics, which is the first 3 letters. So let's say I have a patient that is on a VVI mode. What does it tell you? Crickets. Anyone? Goreng je. Or Dr. Khairul will randomly select the victim. So again, paste, sense, response.
Paste the ventricle.
Okay.
Sense rate of ventricle.
And
then the third one.
What is I? Inhibit. So what is it? So let's say so what does it tell you? What does it tell you if there's a signal that goes to the ventricle in a VVI? Maybe Dr. Khairul will find someone else. Kata nak jadi specialist. Kenalah jumpa pacemaker.
You all please Google VVI and now you all have handphone, right?
We go to basic. There are 2 basic modes. The most basic is either VVI or the paling basic. Anybody, have you seen a transvenous pacer? Anybody, have you seen a transvenous pacer placed by cardiology? Medical? No? You're all so young. So because sometimes the cardiology will also insert a transvenous pacemaker into the heart. So obviously it's gonna be a VOO. Everybody is Googling. So you can either Google VVI or you Google VOO, and then we will chit chat about it. 1 minute, 1 minute. I think that's enough Googling. Okay, somebody tell me what you understand about VVI. Cuba goreng.
VVI is ventricular pacing and sensing.
Okay.
If no ventricular impulse sense, then pacemaker will pace at a pre-programmed rate.
Okay.
If ventricular impulse sense, then pacing is inhibited.
Okay. So what does the third letter tell you? What is the true definition of what the third letter tells you? It is a response to a sense signal. Faham tak? So let's say you have a okay, give me an indication for VVI. Anybody? Goreng. Any tachyarrhythmia? Are you sure you're gonna put a VVI on a tachyarrhythmia? Wrong. Next. Okay, what kind of heart block? 3rd degree. What else? Part of the indication. Morbis type 2. So if you have a Morbis type 2 or symptomatic type 2, you have a 3rd degree heart block, you're gonna need a pacemaker to pace the ventricle. If not, the patient's heart rate gonna be 35. So you're gonna put a pacemaker. Let's say this patient miscane, hospital pun miscane. So you're just gonna put a simple pacemaker, put it on VVI. So what's gonna happen? So it's gonna be pacing the ventricle, sensing the ventricle. If there is a signal, it will inhibit the response. Which means that, let's say if the patient's AV conduction is intact, and then there is signal that travels and reaches the pacemaker, then the response will be such that it will inhibit a response, inhibit a pace. So there will not be any pacing. We just let it be lah. Inhibit and let it be. So that is I. But what is VOO then? You pace the ventricle. O means no, doesn't sense anything. And then the response is no response. So let's say lah, I put this patient on a transvenous pacemaker. No, not me lah. Let's say the medical puts in a transvenous pacemaker, and the patient goes to OT, and then I'm gonna set a rate. I'm gonna set a power. So it's a VOO. That pacemaker doesn't care what's the patient's intrinsic rate. It's just gonna give whatever, because the response to a sense signal is O. It's not gonna do anything. It's not doing anything. So it's an asynchronous mode. Asynchronous mode, which is in the past what they tell you to do, right? Pacemaker management, right? Pernah dengar? Oh, but because all you young ones never seen pacemaker, so you don't think about how to manage them. So in the past, people always say, "Oh, put a magnet near the pacemaker, put it to asynchronous mode." Basically, it's gonna put into VOO. So it's just gonna give a signal at a certain rate without care about whether the patient has his or her own intrinsic rate. Is there a problem with VOO in theory? I'm just gonna spike every 1 second. Is there a theoretical risk of harm? You angguk kepala, why? You're probably right, but why? Why do you think there's potential harm if I'm gonna just asynchronously give the patient spike every second without care of the patient's own cardiac cycle? What is R on T phenomenon? What is R on T phenomenon? Okay, it may induce tosa de pois, but basically, what does it tell you? At the end of the day, what is it? It's basically giving a stimulus during the T period, kan? Yeah. So you're gonna induce arrhythmia. In practice, how many of you have cardioverted a patient electrically? A lot of you, kan? Don't tell me you guys are so young that you've never electrically cardioverted a patient. So let's say you're gonna cardiovert an AF. What's the first thing you're gonna put on? Sync, kan? You're gonna synchronize so that you will deliver the shock not during the T wave. So it's going to be synchronized so that you do not give it during that period. Because if you give it during that refractive period, you're going to cause a VF or a TOSA. But mainly the main worry is VF, because there's going to be zero cardiac output. And so that's a theoretical risk of an RNT phenomenon if you're going to put a patient on an asynchronous mode. But sometimes, but putting a patient on VO is very easy. I mean, but of course, if you're going to put a patient on a transvenous pacemaker, it's probably not going to be possible for it to be so sophisticated to put it like a VVI mode. Have you ever guys seen a DDD? How many of you are from Sedang? Sedang ada? How many are from Sedang? Semua tak berani angkat tangan dah. Because they know I'm talking about cardiology patient. Alasta pun tak berani dah. They all run away already. So, have you guys ever heard of a CRTD? Cardiac resynchronization therapy device? So, it's a special pacemaker for patients with heart failure. So it's basically a DDD mode. So, it's going to sense and pace both the atrial and ventricle. But on top of that, it's actually a biventricle pacing. So that the contraction of the ventricle are all synchronized. So that's a special device. So that's the easiest way in terms of pacemaker is the first three letters. Okay, the fourth and the fifth is rate modulation. These are all the advanced features, rate modulation as well as programmability or anti-tachycardia function. So basically, rate modulation means there is a way for the pacemaker to increase the heart rate. For example, when the patient is feverish, actually exercise kan, so the temperature rises, so it will increase the heart rate. So there's a rate modulation capability. And some advanced pacemaker, they actually have anti-tachycardia function to deal with patients who have tachyarrhythmias and not just bradycardia. Okay, so that is pacemaker. Head boiling already. Oh, ada yang angguk. Okay. Let's boil some more. Okay, so next, ICD. What is an ICD? Implantable cardiac defibrillator device kan? Cardiac defibrillator device. So how many letters? You guys were not prepared for this topic, right? But that's the MCAI for you because these are the questions that come out in MCAI. If you're just gonna study physiopharmaco, you're gonna get surprised by the questions that come out because MCAI has a much broader syllabus, even though it is not as deep as first year masters. So ICD has mainly 3 letters: short chamber, anti-tachycardia pacing chamber, and 4 letters, and then tachycardia detection chamber, and then anti-bradycardia pacing chamber. But that one okay lah, tak apa, tak penting. Okay, nanti you all boleh baca. But even before we talk about ICD or pacemakers, okay, so how many types of cardiac implantable devices are there when it comes to arrhythmias? How many types are there? Which types have we discussed just now? Pacemaker and ICD. So you also have, like I mentioned before, CRTD, cardiac rhythm therapy device. And then there's one more. It does nothing but record. What is it called? Loop recorder. So basically, it's an implantable cardiac device that does nothing but record. It has no intervention function. Okay. I think some of you are gonna boil and cry. Okay, but never mind. Let's cry some more. Pretty sure you see this in your day-to-day practice. How many of you from Sungai Buloh? Wah, matilah. Who from Sungai Buloh? Semua tak nak mengaku from Sungai Buloh. Anybody from HKL? Ada seorang tu HKL kan? Tell me about that city brain, the leftmost. What do you think is that? SDH. Oh, how many of you agree with him? He said it was an SDH. How many of you agree with him? How many of you disagree with him? Okay, yeah, there's somebody up front who disagrees. I like dissenters. Road not taken, eh? So, tell me, why you disagree? Why do you disagree that it is an SDH?
It's an EDH. EDH.
EDH. Why do you say that this is an EDH?
The shape.
The shape. What about the shape?
Looks like an I is a start of E. So it's EDH. It's easy to remember. Okay,
so you have to remember the main way to differentiate EDH and SDH is that an EDH will bulge into so it appears like a lens, while an SDH will remain relatively concave. So what else do you see on this city brain? Is it just an EDH? Okay, never mind. First, which side of the brain? Right side. Okay. Which region? Parietal. Okay. So what else do you see? What has happened? Midline shape. What else happened? Edema. Okay. Local edema. Maybe there's globalized edema. But what else? What happened to the ventricle? Compressed, right? So which ventricle are we talking about? Right what? Lateral. Right lateral ventricle kan? So that's the first city brain kan? This is my actual exam lah. I mean I just took the picture, but definitely my OSCE, one of my OSCE stations for the MCAI was city brain, pathological city brains, and diagnosing the CTs. Okay, so let's look at the right upper. What do you see there? What is there? Huh? Who wants to speak on the mic? Somebody wants to say something. I can't hear. Never mind. You probably heard about it once upon a time in your life. What lesion do you think that is? Where is the lesion? On the right side. Okay, maybe you're right. What lesion do you think that is? What do you think that lesion is? Never mind, don't be shy. I don't eat humans. SAH. You are correct. You are correct. So basically, if you see blood within the sulci gyri, so and suddenly you can see the outline of the brain very well. I mean, you compare to the one on the left hand. Of course, there's cerebroedema, so there's poor gray-white differentiation on the left side, but you can see that on the right, suddenly everything is brighter. So when something is bright, which means there's blood in the subarachnoid. Subarachnoid space. So that's the appearance of an SAH. Okay, so what about the one on the lower right? What's the lesion? What's the lesion there? Make a guess. The one on the lower right, what lesion? You can either describe and teka or teka and describe. What do you think? Tumor? Let's say this is a 50-year-old man. They plan to insert a VP shunt. Why? I already gave you the hint. Soalan bocor already. That's not what I'm trying to have you answer. Do you see a SOL there? No, right? I mean, it could be due to an SOL, but what is A, B, and C? Somebody want to bebel kat depan. Give the mic to him. Yeah. You're masochistic kan? So you like to answer question. Okay. What do you think? Okay, probably it's a obstructive hydrocephalus because you see that A is your basal assistance effaced, B refers to your lateral and third ventricle dilated, C refers to your sulci being effaced. Don't think that you as an anesthetist don't need to know anything about the primary problem. I think especially when you want to, I think as you go along your career, you move up a ladder in terms of your responsibility and things like that. You need to know what is the problem, and because when you know the problem, then you can plan properly lah. Because there's no cookie cutter approach to everything in your plan. Ideally, everything is individualized. Even though if you look at the guidelines, a lot of things they don't really matter lah. Right? But of course, if you're going to anesthetize a patient with the hydrocephalus, you gotta be worried about the patient's central nervous system function. Obviously, if they are posted for a VP shunt, obviously they already have hydrocephalus, but you have to be able to identify. Okay, battery is running out. Segue. Okay, how many of you have ever met a vaporizer or seen a vaporizer? Pretty sure all of you have met or seen a vaporizer. How many of you have ever seen isoflurane in action? Not me lah. Huh? Okay. So that's a vaporizer right there again. So the upper right corner refers to what kind of vaporizer? You might think it's not related to your exam. Especially for MCAI, it definitely is part of equipment. In terms of masters, it still is related because it's related to your physics of your volatile agents. So the one on the upper right refers to which agent? The one on the lower right refers to which agent? Answer. Tembak. There's only a right or wrong answer. Sorry? Which one is SIBO? Like duh. I'm talking about the diagram. I'm pretty sure that my that my first daughter can also tell me that the one on the left is SIBO. But which diagram? The upper one or the lower one? Which one is SIBO? Okay, you are correct. So, what kind of vaporizer? Okay, somebody else. What kind of vaporizer is sevoflurane? Your modern sevoflurane vaporizer that's typically used in KKM. We are not talking about Aladdin cassette, eh? Oh, okay, nobody triggered, which means nobody has encountered Aladdin cassette. Okay, so your normal vaporizer in KKM hospital, sevoflurane. What kind of vaporizer is it? Huh? No. What kind of vaporizer is it? How does it achieve the intended goal of giving the concentration that you set on the dial? I thought I heard somebody say blend. I guess have ever heard of a plenum? Oh, okay. Okay, so sevoflurane, isoflurane, these are all plenum vaporizers. And the mechanism that they use in modern vaporizers is variable bypass. Ever heard of it? Ever heard of the term variable bypass? Oh, banyak benda kena baca ni. So that's why when you have a so when you have a vaporizer using a variable bypass, so you're gonna set the dial, and then the dial is gonna change how much is the bypass flow going to be. So you have your main flow, and then your flow that's gonna go through the wick system, and then it's gonna be fully saturated. So the key with modern vaporizers is that they're going to make sure that the bypass flow is gonna be fully saturated with vapor, and then it will rejoin back and then go to the patient. Okay, but of course that's not the only thing that needs to be taken into account, because as evaporation occurs or the temperature in the environment changes, then the vapor pressure is going to change, right? You guys have heard of vapor pressure? Kena baca lah. So what is vapor pressure? What is saturated vapor pressure? So these are all things that are going to change with temperature. And as vapor evaporates, what happens? What happens to the system as the liquid evaporates? The temperature becomes less, kan? I mean, that's why you sweat, kan? Why do you sweat? To look sexy? No, right? Just to cool yourself down. So when you sweat, you're gonna evaporate. There's gonna be heat transfer to have the liquid be changed from a liquid phase to a gas phase, and then it will cool the system down. So as the system cools because of evaporation, so the vapor pressure is gonna be different because the temperature has changed. So that's why modern vaporizers, they have a temperature compensating valve. So whether it's bimetallic strip or whatever mechanism to account for the change in temperature. Okay, so this is a typical plenum vaporizer for your SIVO or for those yang older than Dr. Khairul, isoflurane lah. Atau even older than that, Dr. Melo, halotane lah. But we young ones will only see sevoflurane and desflurane. But why is the design of desflurane different from sevoflurane? I mean, first of all, when you come to work as a few months old anesthesia MO, what do you see is the main difference between sevoflurane and desflurane vaporizers? Color? Don't tell me color. Heat. Okay, it's heated, which means that it has its own external power, kan? It's the only vaporizer in town that needs power, that needs electricity. The rest do not depend on electricity. So that's because desflurane is highly volatile. So that's why for desflurane is what you call as a measured flow vaporizer. So it has direct injection into the gas flow in order to achieve the desired concentration output. So that's because desflurane is highly volatile. If you look at the if once you study later about the anesthetic volatile agents, you will find that desflurane has the highest vapor pressure among all the other agents, and it is basically near boiling at room temperature. So because of that, any change in the temperature is gonna lead to a huge change in the vapor pressure, and how you're gonna compensate for that. And so because of that, they need a special desflurane vaporizer where desflurane is actively heated and it is pressurized to a fixed pressure, 1.5 kmm Hg. So when you have fresh gas flow, so this desflurane vaporizer will have a fixed resistance here, and because of that fixed resistance here, there will be transferred pressure which will be detected by a differential pressure transducer. So based on this differential pressure transducer, there will be an adjustment in the amount of released desflurane into the mixture. So you're going to set how many percent, but how much is being released, it will depend on the differential pressure transducer. Of course, if you're going to put a high fresh gas flow, there's going to be a lot of pressure difference, and therefore more desflurane is going to be mixed in order to achieve the desired concentration. As compared if you have a low fresh gas flow, a low differential pressure, then the variable resistance here will be adjusted, and there will be higher resistance, so less release of pressurized and heated desflurane into the output. Because vaporizable was part of my MCAI MCQ, but I can't remember what was exactly asked. But it's definitely part of it. So are your hands already boiling as well, like desflurane at 40 degrees? Okay, so you still have mental energy. We try lah. So FCI level questions. If you go to my blog, you can have a look and see whether your mental state is tortured. Okay. Because at the end of the day, MCI, you still gonna have some clinical questions as well. I remember my clinical exam question for MCI level was pre-assessment for patient with CKD. So it will be asked during OSCE. Part of your station in OSCE MCI is CPR, resuscitation. It's gonna be there. So that's why you can't focus on just pure physiopharmaco. Or if you're planning to take the parallel pathway. Okay, so let's say you have this scenario, since tak ada siapa yang mengaku, okay, so tadi ada seorang yang HKL tapi tak ada siapa mengaku Sungai Buloh, tapi Farid dah pernah Melaka, yang pernah neurosurgical kan, tapi tak pernah nasib tak cakap soalan bocor. Okay, never mind. So let's say a 35-year-old man with DM, hypertension, ischemic heart disease, with morbid obesity, came with a severe acute headache. What do you think is the most grave diagnosis? Huh? ICP? ICB. So, what kind of ICBs do you think can be associated with these severe headaches? SDH, SAH, okay? SAH lagi? Intraparenchymal hemorrhage kan? But basically main thing is SAH. Okay, so have you guys ever heard of gradings for SAH? No, okay. So these are from my notes. So if you're gonna take the parallel pathway, I'm sorry because I like cursive. So they will ask you about the grading of SAH, whether it's gonna be based on the WFNS criteria, Hess and Hunt. I mean, you don't have to memorize everything lah. You just have to know that there are 3 ways to grade: WFNS, Hess and Hunt, and based on Fisher CT scan. And then you choose one criteria, and then you hafal lah. What is the grading of the SH that you want to know? Okay, so who would sedate this patient for CT scan? This patient tiba-tiba restless. Who's gonna sedate? You want to send this patient to CT scan. What are you gonna do? Would you sedate him? BMI 45, SpO2 90. What do you think is the safest way to get this patient imaged? Intubate. Okay, fine. That's a possible method. Okay, so let's say you decide to intubate. What is your concern if in intubating this patient? Okay, high BMI lagi, IHD lagi, possible ICB. What are you worried about if it's a possible ICB? So whether the ICP is high, your hemodynamic fluctuations. So if you have hemodynamic fluctuation, it's not going to be good, right? So, and then you have your high BMI, so you worry about difficult airway. You're worried about IHD. So if you have IHD, intubation is a stressful period. It can cause further ischemia and failure. So there's a lot of things that you need to be worried about. And then patients who are hypertensive, is there any concern about intubating a hypertensive patient? Your experience, do you think intubating a hypertensive patient is the same like a non-hypertensive in terms of the response? No, right? Hypertensive patients will have an exaggerated response. So they tend to have hypertension and then they get hypotensive. And so they have an exaggerated hemodynamic responses. So, part of neuroanesthesia is always going to be about your neurophysiology, kan? So who here has ever heard of the Monroe-Kelly doctrine? Okay, you've heard of it. What do you know about it? Okay. Okay, excellent. So, like our friend here mentioned, so the head is a closed space. So understanding the Monroe-Kelly doctrine is very important for neuroanesthesia because you have to understand that the cranium is a closed space. So, and then you have 3 components. You have your brain tissue, you have your blood vessels, and then you have your CSF. So any increase in one component has to be compensated by the other, or else you get a rise in the ICP. So, when you have a patient in homeostasis, initially the patient will be able to compensate, so the ICP remains static. But once compensatory mechanisms are exhausted, the brain cannot absorb any more CSF. There's no more vasoconstriction if you're going to induce it. So then what happens is that the ICP is going to rapidly rise because the cranium cannot expand. Unless if you are a neonate, in which the brain can definitely expand. So that's one thing. So anyone ever heard of NSM? Neurogenic stunned myocardium. How many of you have seen ECG abnormalities on a patient with SAH? Oh, korang semua betul-betul muda, very young. So I think next time whenever you see a patient with a medical bleed, medical intracranial bleed, you have to look at the ECG, because ECG changes are common, and these are and especially with SAH, they are basically myocardial injury caused by the ICH itself, and this is what is termed as neurogenic stunned myocardium syndrome lah. So NSM. So you will need to understand what is the implication of this. If you higher level question. Okay, so tapi susah nak tanya soalan because semua tak pernah neuro NS kan. So yang lain soalan macam not suitable for you guys. Never mind. We will go to another scenario. Okay. What's a woman? We can talk about it in the medical sense. We can talk about it in the political sense. For those who know about what's going on in the western side of the world, so it is a valid question. What is a woman? But in Malaysia, since we do not support LGBTQ plus stuff, so our discussion of what is a woman will be restricted to medical issues. So anyone of you ever heard of the woman trial? Wow. 0 hands, huh? So I think even in masters pun, in the clinical exam, in the final year, and then especially in the FCI level, they will ask you about landmark studies in anesthesia. And these are things that you have to take note lah. For example, like in terms of the SAH, so one of the landmark study was the ISET trial. So ISET trial showed that if you have a patient that can be coil versus clip, then coil has better outcomes. So the woman trial is actually a trial about tranexamic acid for patients with postpartum hemorrhage. So how do you define postpartum hemorrhage? So that's probably massive lah. Massive obstetric hemorrhage is 1.5 liter. So of course there are many definitions. So postpartum hemorrhage, some people they classify in terms of the mild, they classify less than 500. Some say more than 1,000. So SVD more than 500, Caesar more than 1,000. But there are many definitions of what is major obstetric hemorrhage. So most will take 1.5 liter rapid blood loss as a criteria. There are many criteria if you look online. But basically what the woman trial did was they looked at the effect of giving tranexamic acid for mothers with postpartum hemorrhage. So of course, you're gonna need to know what is postpartum hemorrhage. You're gonna need to know what is major obstetric hemorrhage. This is actually my exact FCI Viva question. So I'm not lying. I don't lie too much. So, and they did ask about what is the woman trial, what is the intervention, what are the outcomes. So of course, when you look at a study, you want to look at what is the primary and secondary outcome. Since most of you basically don't know about the woman trial, I will just tell you that the primary outcome was all-cause mortality, no difference. While the secondary outcome was mortality from bleeding, which there was a slight difference, where the p-value is less than 0.049, but with the NNT of 267. So if you read a paper, what is NNT? Make a guess. What is NNT? Number needed to treat. So in this woman trial, for you to reduce the loss of one mother's life from obstetric bleeding, from death from bleeding per se, so you need to give tranexamic acid to 267 women. Then you save one life. That's a very high number. So that's why they also talk about fragility index. So these are biostatistic topics. Don't think that you are taking postgraduate studies in anesthesia, you can run away from biostats. You take master's degree, you're gonna run into biostats because you're gonna do a thesis. You do FCI, they're gonna ask you about statistics even during the membership level. So you need to know. So you need to actively start reading journals and see what they are talking about and make your own interpretation. So even though this woman trial is very good in terms of statistics, but it's not very clinically relevant in the sense that you give it you need 250 women to improve the outcome in your patients. And it has a fragility index of 0, which means that because the primary outcome was already non-significant. So it's very easy. Let's say suddenly by random chance one patient turn away the other way around, then suddenly the results become very insignificant, and therefore there's no change in the outcome. So those are things that you need to look at. Yeah? Even when you are doing at whatever postgraduate level, you're gonna have to look into statistics. And then when you start presenting, some of you will ask you about the study methodology, the results given, because I will tell you that statistics is just a lot of statistics is just damn lies, because the author can publish according to what the author wants. And this is even more true if you look into meta-analysis, because let's say if they suddenly exclude this paper, exclude that paper, then they will just skew the study results. I mean, they will get whatever they want. So that's why you have to look at anything in medicine. Everything comes with a grain of salt. And I'm pretty sure you have seen that in medicine, a lot of things have turned around 180 degrees during the evolution of knowledge. Like dulu, people die from hemorrhage, and then people say, oh, you must give fluid, and then that's what happened during the Vietnam War. And then suddenly you have all these patients who die because of ERDS, post-trauma, because of being given a lot of fluid. Then you have the trauma lung. I think that's what it's called. And then suddenly during the Iraq War 1 and 2, then the Gulf Wars, then people change their minds, go towards damage control resuscitation, limited resuscitation. Then suddenly patients improve in their outcomes. And then in Afghan War, then they talk about hemostatic resuscitation. So that's why a lot of medicine is never really fixed. It's never really fixed. And that is why I always go and read journals. But at the same time, you have to see when were those journals actually published, because the knowledge will change. Some of like macam PDPH, people think PDPH is due to the fact that you are using an atraumatic needle. But when you think about it, when you look at the electron microscope, I mean, you use a spinal can. Spinal can is a cutting needle. How is a cutting needle less traumatic than a blunt needle? The blunt needle will actually cause more trauma. So people are now thinking that maybe the reason why patients with laser point needles have less PTPH is because it causes more trauma and therefore more inflammation, and therefore the hole closes faster, as compared to what was previously taught as part of the theory. I mean, that's medicine. Medicine always evolves, and therefore you have to keep with the times as much as possible. But of course, it's not easy, because I'm pretty sure during the Kairos time, medicine was much less narrow than it is now, and it's gonna only become the knowledge is gonna become wider and wider in the future, and you guys are gonna have a lot of trouble trying to efficiently learn as much as possible and filter things out. And your textbooks are always gonna be at least 5 years too late. That's a fact of publication, and textbooks are always gonna be the safest, so it's gonna always be outdated by the time they are already published. Any questions? Part 2. Or you guys want to cry? Or your brains are boiling? Wow, really no questions, huh? Either you guys understand everything or or heads are boiled. Okay, if there are no more questions, thank you.